Anti-reflux surgery is an alternative to long-term medical therapy and is also offered to those with refractory symptoms, unacceptable drug side effects, a large hiatal hernia, severe esophagitis, or complications. Some of the complications for which surgery is indicated include enamel erosion, benign stricture, Barrett's esophagus without high-grade dysplasia or adenocarcinoma, and recurrent pulmonary infections. Unfortunately, surgery is unlikely to be of benefit to patients who find no relief with proton pump inhibitors. Preoperatively, upper endoscopy with biopsy is needed to check for malignancy, and manometry is needed to rule out contraindications to anti-reflux surgery, such as achalasia and esophageal hypomotility. Now there are 3 more tests that need to be considered. If upper endoscopy does not reveal esophagitis, then the diagnosis of GERD becomes uncertain. In these cases, an esophageal pH impedance study should be performed preoperatively. An upper gastrointestinal series is used to evaluate the length of the esophagus and, if present, the size of a hiatal hernia. And when the patient history gives reason to suspect gastric outlet obstruction or gastroparesis, then gastric emptying studies should also be considered. The preferred surgical procedure is the Nissen fundoplication. In obese patients, however, gastric bypass surgery may be preferable. Complications of the Nissen fundoplication include gas bloat syndrome, dysphagia, increased flatulence, and diarrhea. Surgical intervention does not reverse nor prevent the progression of intestinal metaplasia of the distal esophageal mucosa. Surveillance for esophageal cancer with upper endoscopy is recommended for patients with Barrett's esophagus, even if the patient is asymptomatic.